Yeah. Because I had the same experience this week.
Oh wow.
But me was the opposite. We found the babies, so we had to hunt the mother.
The what?
Mice in the garage.
Oh.
Apparently, this is something very normal for West Virginia.
Why is this person laughing?
I have no idea who that person is.
Okay.
Who?
That wasn't at work though, right?
Huh?
Not at work?
No.
Okay. I was like, please don't tell me have mice in the call room because I cannot deal with that.
All right, Andy, you can go ahead whenever you are ready.
Just like for a second before you start, for the future reference, guys, like when there is like a supervisor,
No, but
an attending supervisor with your lecture,
you are not on me. Take this down. You are ready to go whenever you want to.
Okie dokie.
so when you have an attending supervisor with your lecture, you have like first of all you have program director, associate program director, two of them, like so you can complain if no one like supervising your lecture. But if you have attending supervisor in the lecture, you have to run it by your supervisor to pick the articles, the topics, like is that a good thing? Is that a bad? Is this study valid or not? Should we, because like this is, it's not a fellow to fellow teaching program. It should be like supervised by the attending, is that right? So I can like just give you and prepare a lecture, and I'm looking at you, Shaheen. Like,
Because you always do another.
so like I don't know like how it works in here, but it should be you review the presentation, you look at the presentation as an attending. If like he's not if he's busy or attending like he didn't answer you back, like you have like little Jasmine here, like, hey, that's what's going on, and I'm doing this and this. Can you please talk to him because like my presentation is in a week and no one sit with me and discuss with me. All right, guys, please.
And make sure that
To make it a good
not
conference,
just a few days.
because by fellow by himself, yes, you're good guys. Yes, I trust you all guys. But it's always better to have like even an attending to attending. Like my presentation will be better if I show it to Al Jasmine before I present it, because he has like different perspective, and vice versa. So that's why you usually like try to set it up with the attending at least a month before your presentation. Say, hey, by the way, just a reminder, I have this with you. Like, do you need like a specific articles I need to review, or what exactly you need to review before we start?
So the way I would do this, the moment their presentation, like just ask your attending, is there something like an outline or something you want me to talk about? Like you said, it's a very good point. All right, that way it can guide you in the beginning, and then maybe just a week or two, ideally 2 weeks before, set a draft. Like I said, we give you these presentations a long time before you guys start, before you guys, plan. So if your plan is in 4 months, the goal is not, I'm not giving you 4 months to start it 2 weeks beforehand. I'm giving you 4 months so you can start brainstorming, maybe just researching the articles and things like that, beforehand and things like that. So if you send that, if you're attending your lecture 2-3 days before, he will not give you any useful input. Or if he does, it's going to be, you're not going to have time to add it to your lecture. So it's going to be useless. So it has to be a little bit beforehand.
Because in your level right now, it's not just like telling us what you found, but it's arguing with the articles, arguing with what's going on right now, and what's the guideline, and what should we do next, and should we follow this? Is there like an article we did not see? That's why how we're gonna learn from you, and that's why like an attending an academic program, he will keep learning, because you guys like you learn and teach us more than we teach you. It should be like this. So, but that's with an open discussion, not just like sitting and preparing something by yourself. Okay, Rami?
That's what I'm fine. I sent it 3 weeks before and no response. And as you said,
No, that's we're adult and we
else.
are like in grown up. So like
Very
as I
good.
told you, like if he doesn't answer, that's why there's a program director and an associate program director. That's their job. All right, sorry, man.
Okay, you're good. All right, so nutrition in the ICU. Topics for today. There's a lot of them. So first, just a little pathophysiology to kind of give us a nice background and tell us why it's important. So pathophysiology of malnutrition involves stress catabolism and inadequate nutrition intake, and that leads to a negative energy balance and gut dysfunction. Critical illness activates neuroendocrine, inflammatory, immune, adipokine, whichever way, GI tract hormone pathways. And these increase serum glucagon, cortisol, cholecylamines, and promote glycogenolysis, gluconeogenesis, insulin resistance, protein catabolism, and restricted or impaired anabolism. So increased metabolic demand in critical illness can lead to breakdown of lean body mass, and that can contribute further to malnutrition. During such states, it's a priority to provide adequate nutrition and optimize function to promote appropriate host immune response. Most critically ill patients have a low nutritional reserve and are kept in PO a lot of the times. Or, we frequently interrupt their feeds for whatever reason, and that just contributes to worsening malnutrition. So nutrition plays a key role in the modulation of inflammatory responses, maintaining the immune function and slowing skeletal muscle catabolism, promoting tissue repair, of course, and maintaining mucosal barriers in the GI tract as well as pulmonary. So there's a lot of guidelines, there's a lot of studies that are out there on their own, but there's a lot of different guidelines as well. I kind of just chose these four because they are fairly well established. They're different committees, they review evidence, and kind of looked at the different recommendations that they had. So that was at least the approach that I took to it. So for the Canadian Clinical Practice Guidelines, their last major publication regarding nutrition in the ICU is in 2015. It summarizes evidence from about 354 randomized controlled trials in the area of critical care nutrition that have been out since 1980. The included studies have undergone a formal review process by their committee, and they try to provide the latest and best evidence for clinical practice, revolving around nutrition in the ICU, of course. And then the next one, the European Society for Clinical Nutrition and Metabolism, they publish guidelines to define the patients at risk, assess the nutritional status of an ICU patient, how to define the energy to provide, like the amount of energy to provide, what route to take, and how to adapt according to different clinical situations. There is some special attention given to like specific nutrients. I didn't really get into that because it gets a little bit convoluted. But then they also pay attention to frequently observed conditions in the ICU, dysphagia, frail patients, trauma, abdominal surgery, sepsis. And their guidelines are basically, a framework of evidence that they've come up with and expert opinions that are kind of put together in a structured consensus process. The studies are from an unlimited time span. They didn't really specifically say, but they did say they only assessed studies that were published in 2000 or later for the meta-analysis. The next one, the European Society of Intensive Care Medicine. Again, guidelines and consensus statements for nutrition topics in critically ill patients. The guidelines for early enteral nutrition was the one that was used mostly for this presentation. There's also one about parental nutrition as well, but mostly the enteral nutrition was one that I used today. And it does also focus on some specific disease conditions. They ask questions and answer the questions based on evidence that they find. And then for each question, they have two reviewers that independently search PubMed, Medline, and the Web of Science databases through December 15th. They did restrict language to English, and abstracts without full text were excluded. And then finally, the American Society for Parenteral and Enteral Nutrition published guidelines for the provision and assessment of nutrition support therapy, published in 2016, focusing, of course, on ICU patients. And the guidelines were derived from data obtained by literature searches by the authors through December 31st, 2013. So there's, as we know, malnutrition, of course, worsens the outcomes. It's associated with higher risk for infections, readmission rates. These nutrition scoring methods are a way of recognizing patients that are at risk or already are malnourished. There's several different assessment tools, but only the NRS 2002 and the Nutric score determine both nutrition status as well as severity. The NRS 2002 is simple, it's well validated. It's been assessed in several studies, including randomized controlled trials. It involves a pre-screen of 4 questions, and if one of those 4 pre-screen questions is positive, you move on to the actual screen. Each parameter scored from 0 to 3. Over the age of 70 years is considered a factor. Total score of 3 or more means that the patient is at risk of malnutrition or already malnourished, and nutritional therapy should be started as soon as possible. The Nutric score, it's the first nutritional risk assessment tool developed and validated.
Can you please go back to the previous?
Yeah.
slide as well?
It's kind of small, sorry.
No, I just wanted to see what are they looking for.
So,
I see
the pre-screening, of course, is the BMI. Did they lose weight? Okay. So, I'm not really sure what they use for quote unquote stress metabolism, but age is of course one. Yeah, they do weight loss, reduce general condition. It's not as good as the other in my opinion, but
But the last one, severe is they have a Apache score.
right.
So what do we do based on these scores?
I'll tell you here in just a second. Stay tuned. You're fine. The Nutric score. Let's see. So this takes into account age, Apache score, SOFA, number of comorbidities, which if you look on the right side, those are all considered comorbidities. Days from hospital to ICU admission, and then the IL-6. And they give scoring based whether or not IL-6 is available, because they know that's not something that's commonly available as like a point of care kind of thing.
More realistic.
This is more realistic for sure, yeah. These two are what was mentioned in the guidelines. This is why I'm kind of talking about those. But for the Nutric score, if you do have the IL-6, 0 to 5 means they're low risk for malnutrition. 6 to 10 means they are at risk. And so those that are considered to be at risk are more likely to benefit from more aggressive nutrition therapy. Of course, everyone would benefit from nutrition therapy, but more aggressive in those that are at risk, if that makes sense. So for enteral nutrition, obviously PO intake on their own is what's preferred, but that's often not possible in our patients. So the next step really is for enteral nutrition. The whole point of enteral nutrition is, of course, to support the functional integrity of the gut, maintain tight junctions, stimulate blood flow, reduce release of trophic endogenous agents like cholecystokine and gastrin. Enteral nutrition maintains the structural integrity by maintaining villus height and supporting the massive secretory IgA producing immunocytes in the GALT, the gut-associated lymphoid tissue. So, of course, specific reasons to give, maintain gut integrity, modulate stress and systemic immune response, and, of course, attenuate disease severity. So, review the guidelines. Several topics. These are ones that I kind of picked because they're a little bit more straightforward and relevant, in my opinion. So, for early versus delayed enteral nutrition, so does early enteral nutrition compared to delayed result in any better outcomes?
So what difference to me does it make it at low risk or at risk or at high risk?
So low risk, standard therapy. High risk, you want to really pay attention and start early as possible, like the first day, second day. Whereas other people, like, not delay it, really pay attention to, we stopped the feeds because of this. Try to avoid stopping for procedures that necessarily aren't needed. Does that make sense?
It depends on where you are working. Like,
Yeah.
is it like an ICU that who has a nutritionist in it, or an ICU is driven only by the intensivist? Because like for a real ICU, you should not be like calculating this score at all.
Right.
That's the nutritionist, the one who's gonna calculate the score, but she will let you know that, hey, this patient, they're gonna give him more calories or more proteins or more this because he's a high risk of malnutrition and needs like more like attention are you okay with that, or you're not okay with
Right.
that? As a physician, you have to give the green line to say, yes, you go ahead and do it. Or, hey, this patient has this and this and this, but she's a COPD patient. I prefer to give her this type of diet instead of this type of diet because of this, and she's not in high risk. I will give her like just 25 or like 60% of her target calories, if you're okay with that. So like it helped me to make the decision of like what the calories, when like not when do you start, all of them you should start early, but what's the calorie, and is that okay to stop, and like is there like a very high risk to start even parental, not just enteral feeding?
Aren't you driven by other factors to stop or hold?
Yeah.
That's right. See, like for a straightforward patient, that's the nutritionist will come and tell you in the early morning round or the pre-round, should be like, hey, this patient, we're gonna do this and this. This patient has very high risk of malnutrition. We're gonna increase his nutrition if that's okay with you. Hey, this patient, he's in propofol, but I think that he's getting this type of calorie from the fat. Can we switch to another sedation because I would like to give him more of this than in this? That's in real life.
It's how we should go.
So, to answer this question, they looked at trials where enteral nutrition was started within the first 24 to 48 hours, and all of them but one study, and versus starting it at a later date, like 3 or 4 days, versus the first 24 to 48 hours. So no mortality benefit, but there is a trend towards reduction in mortality. It's a non-significant p-value, but still a trend. Infections. There was a significant reduction in infectious complications on those with early enteral nutrition. No effect on ICU or hospital length of stay, or days on the ventilator. No effect. So when should it be initiated was the question that was asked by the ESPEN. So again, early versus not, early versus delayed. Showed reduction in infectious complications again, but only in the non-ICU patients, because they did include 4 studies that had patients that were not in the ICU. Again, no difference in mortality.
So there's no difference in ICU patients.
Right.
Mortality.
In mortality. In infection, yes. So reduced risk of infection compared to delayed. So early enteral nutrition, meaning within the first 24 to 48 hours, versus waiting until 3 days or later to start it. No reduction in mortality, but reduction in infections.
Why does it reduce infection, by the way?
You know, the bacteria.
Yes, you're
the bacteria.
Sorry,
He's like, I know this, it's fine.
Why does it decrease?
In the Aspen guidelines, they did find a significant reduction in mortality based on a meta-analysis of 21 trials, but again, the rest of them, not so much. So 1 out of 4 found reduction in mortality, but all of them a reduction in infections for sure. For gastric residual volume, since this is something we frequently talk about.
Sorry.
No, you're fine.
When we say early versus late, so early is within
First 24 to 48 hours.
Okay.
And then late is 3 days or later.
Did they say the amount, or do you need to reach
Just
full,
anything.
or just
Anything.
Then I don't know if she's gonna discuss that in the future slide or not, but like then the 3 main studies that discuss the amount, which is most probably she will talk about them, but the EDEN trial and the calories trial and the Nutria trial, all of them like was 2012 and 2013 and 2014, and those are the ones that compare the trophic feeding versus the full feeding. Is it safe to do trophic feeding? Is it like safe to do full feeding in pressors, or like the amount and everything? But not the studies that mentioned early and late. Those are the ones that she mentioned.
What's the name of the scoring?
Nutri. So using higher gastric residual volume before holding feeds lead to better outcomes. And so there was a study in 2010 that compared 500 versus 250. And again, that's the cutoff of where, like if the patient had a residual of 250, they would hold the feeds per their protocol and then restart per their protocol, or if versus 500. No mortality benefit or infectious complication benefit. There were lower GI complications in the 500 group. There were no, I think this is important to mention, there's no difference between abdominal distension, diarrhea, emesis, regurgitation, or aspiration. So leaving a higher residual volume limit did not result in any increased aspiration. And there's a significantly higher amount of nutrition delivered in the group that had the higher residual volume cutoff. Another trial they looked at compared not checking the residual volume at all versus having a limit of 250. No difference in mortality or infections, length of stay, or ventilator days. But of course, the calorie target was achieved in more patients where they didn't check the residual volume, and they had a lower cumulative calorie deficit in the first week in the group that didn't check.
If they don't check the residual, basically
Right,
better method
right.
for nutrition.
You don't know, and you don't get focused on that number.
The question, does it make sense?
Yes. For me, yes.
For me, no.
Why?
If you're like, for example, let's just talk ICU patients. You have them sedation, for example. Okay, they are eating. They have EDs, for example. Okay, food is not passing down. If you couldn't popping it in, what is going to happen? If it's not moving from the other direction.
Do you know they have EDs or not?
It's a clinical assessment.
Okay,
So
so
are they pooping or not pooping?
awesome, good.
Okay, we're already, most of our patients, we're already like numbed their intestine because we are the standard of care is fentanyl for everyone. For example, then we're gonna talk about pressors.
Just go back to your question, why it's not convenience, right?
No, because it feels like, okay, if the patient, okay, if we keep up backing up this food inside his stomach, isn't that gonna cause extra? It's called not aspiration.
Okay, so what would happen?
But this is what
Intestine, workload on the intestine.
What do you mean by workload?
Blood supply for the intestine. It has
Okay,
to work
wait.
more.
That's different. Blood
Yeah.
supply in the intestine, a normal person or a person on pressors? Because that's a big difference.
I agree
We are
on
talking
the-
about a critically ill patient who is in the ICU, not on pressors.
Right.
He's like for, let's say, DKA or like
Respiratory
Nina because
failure.
working up in St. Mary and now he went to
Respiratory
ICU and respiratory failure. That's right, respiratory failure tube, and because of COPD exacerbation. And you start
I'm
the
not talking
feeding.
about this what we call a soft ICU patient.
No, not soft, intubated
What's
patient,
that?
DCC.
Yes, unless
Okay.
like someone.
ARDS, not in shock, intubated.
Can you tell really what is the reality of your blood supply, whether they have like this, this blanking circulation, whether it is.
When you sleep, do you check your residual? When you are at home, do you stop eating because you
I'm
check
not
your
sick at
residual?
home. That's the thing, I'm not sick at home.
Right, but in
So,
general.
the only thing I would say is like you're right. I mean, the concept all makes
Right.
sense, but
But
there are
evidence.
lots of things that make sense that evidence-based medicine tell you to do or
Otherwise,
not to do.
Yes.
So that's why their studies look at the tolerant, not tolerant, but they look at these things, and when they say
Difference
that
in
obviously you have to read the study,
aspiration.
if they show no difference in outcomes, then I would go, it makes sense, what you're giving all this, like, okay, you're giving all this 2P where does it go, does it affect the guts and all that stuff, but if randomized control studies shows that they are not causing harm or they're equal in groups or whatever it is, then I go with the evidence.
So if we take.
No, he's okay with going with the evidence, but
No,
he
I'm fine, but
doesn't make
because
sense or not, that's his
physiologically-
question.
I would even go one step further into this question. Let's say that you are giving the patient 500 ml total bolus within 6 hours, okay?
No, we give him continuous,
Let's,
okay?
let's say, just a random number,
Okay.
okay?
Talk about that too.
According to this 500, this patient is supposed to achieve my calorie requirement for the day.
Good,
If
awesome.
100 only of them make it down to the intestine where it's gonna get absorbed, and the rest of the 400 are staying in his stomach, we're just pumping on top of that. Did we actually even achieve our calorie?
Okay, let me ask you a
requirement?
question. Let me ask you one question. Why did they do this study?
To decrease the work on the nurses?
No. Why did they do this study from the beginning?
I don't.
Because
See,
they
you-
found with doing this, checking residual, they found that a lot of patients under nutrition and they did not get
How
enough
did they define
nutrition.
nutrition? Like,
Wait,
is it
let me
like-
give me just a second. So they found these patients they did not get enough nutrition, which is they would multiple scores, and one of the scores that she already mentioned, Mindy, but like they did not get, there's a lot of interruption because of residual, because they check residual. And we didn't know, maybe you check residual right now, it's 500, maybe in the next second, the stomach will push that down and it will go to the intestine, no one knows.
Exactly.
But they interrupted multiple times because they check. Every time we check residual. But the thing is, like, that's why they said, okay, you know what? One of the attendings said, you know what, let's just do a study without checking and see what's the difference. That's the rationale behind the study, because they interrupted nutrition a lot. That's first of all. But the thing is, you don't know, and I don't know. Like your explanation might be right. There's like an ischemia, or like there's something in his stomach, and it will show up. He will have like constipation, or he will have the food will come out, and then I will say, you know what, stop.
Right.
Done.
Yes.
That's right.
Yeah.
But I don't have to like check it
Right.
to interrupt my feeding, because they found feeding, like less feeding in the patient, that's, as we said, she said, high risk infection. And even when you mentioned in the first study, if you noticed in that there is no statistical difference, but all of the studies showed decreased mortality, but not statistical difference. And maybe if it's bigger, it will show that statistical
Right.
difference.
The other
So-
question is going to be, even if you give what you say, you are giving the, you say that they give the calories. The question is going to be, okay, what happened to these calories after we give it? Did they really go into the patient's system and he utilized their calories?
That's
Or
the
they just-
function of the nutritionist, to
Or
evaluate
they
the
just
patient
pass
every
by,
day.
or they
Look
Right.
at his
I mean, we don't
electrolyte,
know
his
that.
potassium, sodium, all of these things can give you clue if that's getting absorbed or not.
When to stop feeding because of feeding.
That's the major question.
When you
When
stop
to
what?
stop what?
When to stop feeding because of feeding.
What does that mean?
I don't know what that means.
Meaning,
Because of the residuals?
Refeeding or
no,
feeding?
feeding.
Okay.
When to stop tube feeds because of,
Because of, when do you say,
like,
okay,
when do you stop
this
it?
is too much. If I only have reflux back of food.
That's right.
Yes, yes.
Right.
And don't stop it continuously.
Right.
You work it up, what's
Per-
going on, and then if you didn't find anything, you start.
That's the only thing I'll say. So it's, I think, the number you look, but like, I'm not sure if that's what they looked at in the studies, when to stop or something like that, but like most some guidelines, not guidelines, but like hospital policies now are saying stop when you are showing signs that the
Yes.
patient is not tolerating.
Yes.
So how do you show that is not
Abdominal
tolerating?
extension.
Like I said, if you keep giving 2 feeds and the patient not tolerating it,
Or
something will come out of
constipation,
somewhere,
as you
right?
said, or
Yeah.
possibility of
Yeah.
LES, as you said.
Or vomit,
These are vomiting, all of
coming
these are
out.
clinical evaluation. Don't
Yeah.
interrupt it just for the residual.
Yeah, so
Right.
that's a thing. You stop, obviously you don't, but I think you stop at showing signs that patient is not tolerating
Right.
it.
You don't just keep
No.
shoving it down in
But if
there.
we stop it,
Overlooking at the number, overlooking at the number.
Exactly.
but if we stop it and the patient, as Rami said, that is having low GI motility, we need more time to overcome that.
But how do you
That
know that they're
time
having?
the patient's not gonna get the
Transit
nutrition.
time, for example.
Yeah.
You reevaluate, and you know how we start feeding, right? We don't start 70.
Correct. Yeah,
We start 1000, he tolerated well. 20, he tolerated well. 30, he tolerated 40, 50. So he tolerated this to reach this. Is that right?
Yes.
So he did not tolerate this, then I'm gonna go back and see what he gonna tolerate. Let's give him lower than that, with more like concentration of the calories that he has, and see if he can tolerate it or not. And we giving a continuous feed. So, now that's why there's conference.
I don't know if it's going to be discussed in your lecture or not. When not to start.
Never.
I think she has a lot of confidence.
Never. All right. So I will say, like, the way that they monitored some of this, like, calorie deficit was with indirect calorimetry most of the time. I didn't go into that because it's very, convoluted. But again, they measure, caloric targets and calorie deficit mostly with indirect calorimetry. So they do have specific numbers, and then they do the analysis of all of these things. All right. Less frequent checking. So checking it every 8 hours versus every 4. No difference in mortality, infection, or length of stay. There was a trend toward reduction in hospital length of stay when only checked every 8 hours. And then, of course, there was a reduction in vomiting or regurgitation in the group where you monitored every 4, but really no difference in interruption due to internutrition due to vomiting. Of patients who received more than 80%. So the less frequent checking did not really cause the patients to vomit more and result in holding feeds due to
And
vomiting.
no difference in interruption, that's very
Right, no difference in the energy.
So eventually 4 or 8, you're still
Exactly.
disturbing the feeding.
Right. But you're not doing it more often in those with checking it later.
Yeah, I got you. You're
Right.
not achieving anything.
Yes.
So Aspen guidelines asked, should we use them as a marker for aspiration to monitor those patients receiving enteral nutrition? So from 4 randomized controlled trials, raising the cutoff value, meaning, the number at which you would stop or hold enteral nutrition per the local protocols, from a lower number, such as 50 or 100, to a higher number. It did not increase the incidence of regurgitation, aspiration, or pneumonia. So again, higher cutoffs did not lead to worse outcomes. All right, continuous versus bolus. So for the Canadian guidelines, they had 2 studies that compared continuous that they started with 20 to 25, increased by 2 to 25 every 8 to 12 hours, versus bolus. And what they meant by bolus was 100 to 125 by gravity over 15 minutes every 48 hours, and then increased that by 100 to 125. This was the only one that really in-depthly described their protocol, but that's what they mean by continuous versus bolus. And then another one, continuous every 24 hours versus intermittent over 18 hours. So no difference in mortality, trend towards reduction in mortality in those with continuous feeds. No difference in infection, and the incidence of aspiration was not significantly different between the groups either. So there was no difference really in the frequency of interrupting the feeds, the percent goal achieved, those with diarrhea or onset of diarrhea between 2 groups. So some people say, if you do continuous, that leads to more diarrhea. Some people say, you're not going to get as much if you don't do the bolus, and then there you go.
Bolus, when they said bolus, how did they split? Because this is leading to another question.
How did they do what now?
Yeah, bolus, how much is the bolus?
So they, for this specific one, they said starting at 100 to 125 mLs by gravity over 15 minutes, and they do that every 48
And you divide
hours.
the
That's
whole
bolus.
calories for all the day.
Yeah, and they increase it
This
as
brings us
tolerated.
with what we are dealing with now with COVID and pronation.
Yeah, I didn't get into that.
Because there are 2 talks.
So there's
And that's
like a
really
crap
important,
ton
that
of
push the
different
whole-
things that I could have gotten into, but I kind of just whittled it down to these because these are ones that we don't like. There's a lot of information about COVID and all that, like
Yeah.
proning, not
So the
proning, but
question
this
is,
is
yeah,
kind
do
of
you
just
know,
what
guys, what's the question?
So
Do
that's
you know,
on me.
guys, how many hours in here our protocol to go up and feeding?
I don't know.
I honestly don't.
We don't know. Is that right? And I asked the nurse, and she doesn't know.
Mm.
Like the 2 feed rate.
Yeah, I asked the nurse like, how do you go up in this? She's like, when you tell me.
Oh, that's not good.
Patient generated.
That's not
I
good.
was like, okay, good, that's awesome.
I think every.
But they have protocol. They have an order set.
They have a protocol,
yes, they
but
have.
if they're newer nurses, they probably don't know
I looked
it.
it up and they
So
have
24
like,
hours, I couldn't.
it has 4 to 6 hours, I think, increase if there's no this science, this and this and this and this. But there's those like, yeah, when patient, I will just go up.
because I mean the orders like start at this and increase as tolerated.
That's
So
it, so say
that's what the
goal,
order
right?
says, but they do have a protocol.
Yeah.
But if they're
Yeah,
newer
4 to
nurses, they may
6
not know
hours
about
for
it.
Yeah. 4 to 6 hours.
Yeah.
You put the order in, but their protocol is they don't go up. Like if you say this is a high risk patient, he's in a high pressures and like don't go up.
Right.
If you say that's okay to go up as tolerated, they go like with 4 to 6 hours.
Is that what the order says? Just go up as tolerated? That's it?
That's
Whenever
it.
you order tube,
Yeah.
like the tube feed order,
Yes.
just like starting rate is this
Yes.
and go like increase to meet goal as per procedure,
What
per
goal though? Do you
protocol.
have to put
Like,
a goal in? Do you put a goal in?
Yeah, they usually
we
put
do,
50.
or sometimes
No,
the nutritional therapy people do.
It's like a
Calculate,
Yeah.
and she should give you a proposal.
No, sometimes the nutritional therapist does, right.
But,
Yeah, that's
sorry,
fine.
we're
It's fine.
deviating a little bit
It's
from
fine.
it, but you don't need nutrition to tell you a goal. Like, for example, like, you just don't start at 10 and just come in, let's say,
Go
let's
to
say if it's
1,000.
Saturday, and it will not go up
Straight up
to
until it's
Monday
about-
because nutrition comes in on Monday, for
Nope.
example, right?
Exactly.
So you can go up on it. So do you
Yeah.
do you just put 10 and just walk away? Or do you
No,
put
they
10?
put
You put
usually
the-
40 or like some
40
like,
or
they put
50 or
numbers. I
whatever.
don't know how they calculate it. I saw the resident like one.
Yeah,
They
some
put
of them do it by
40 for
weight based.
everyone,
Calculate.
some like they put 50 for.
Okay.
They don't calculate like how many calories this
No,
patient.
they
Yeah,
just
but
do like,
I-
you weigh this
that's
much,
the-
yeah,
yeah.
you should probably get this much.
That's
Okay.
right.
Very non-
Okay.
to calculate.
But it's not that much.
Medical.
To be
I
honest,
did it
you
in
have
my
better
residency,
calculators.
because you have to take into considerations propofol, you have to take into
Right.
No, he
D5.
said like just for the
But
week.
just like on the weekend when you don't have the
I would do
nutritionist.
10 and then go 10
You
by
can
the
slowly
other day until the
graduate.
nutritionist
Okay.
come on Monday and do her math, because
Alright, yeah, no, I
it's
agree, I
very
agree.
changing.
I just wanna make sure you don't keep them
So
at 10
how
for
do
3,
you
4 days.
calculate it when the patient
Yeah,
doesn't
I
go?
don't
I'll
know.
go back to
It's- it has
This is-
Keep
equations.
going.
That's a
Sorry.
big cup.
You have to compensate for protein requirements, calorie requirements, drips, it's.
Go ahead, Mandy.
Sorry.
There's a lot of like there's a lot to talk about. So again, I just kind of picked some of these topics because there's just too much to really get into. All right. Yeah. For the Canadian guidelines, patients receiving continuous feeds, larger amount, and they tolerated it better than those receiving intermittent. Now, what they qualify as tolerating better, I did not specifically put in here, but that's in their overall recommendations. There you go. All right. Does intermittent have an advantage over continuous? Meta-analysis of 5 studies showed a significant reduction in diarrhea with continuous versus bolus. Yeah, those were the only 2 that really commented on continuous versus bolus. Gastric versus small bowel feeding. Does it lead to better outcomes if you use small bowel versus, like ND versus NG? In one of the studies they included, only 34% of patients were able to achieve small bowel access because that's a common problem. If you don't have a quick way of getting it, not all the nurses can place them. You can't always get IR to come up. So they did the meta-analysis with and without that study, considering only a third of the patients were able to achieve bowel access. So
30% achieve what, sorry?
we're able to achieve like
In the
ND tubes.
Yeah, that's the.
Yeah. Because we often have that problem
Yeah,
too.
I mean, I have the same issue, so that's just hard to get it.
So,
to
like,
Yeah, you
most of
can't
the-
you just can't get it.
Like
So
there is hospitals, they just do the POF.
right,
And
right.
That's it.
Yep.
The POF.
Here we
No
don't.
regular NG.
Here we don't.
So the successful rate.
But even
is
even the
30%?
jump of those, I mean, that sometimes I had a hard time getting
Goes,
to
yeah.
the one.
But they go with the magnetic
Right.
thing.
Oh, really?
So
Yeah.
what they're saying is they included
No,
16
it's like
trials.
smaller.
In one of
It has
those
a
trials, there was
magnet,
only
GPS at the end of it.
34% of the
So
patients
you
were
put
able
that
to get
magnet
ND
in,
access.
where exactly
So that
it
could
is.
affect the results. So they did it with and without it. Does that make sense?
Yeah.
It's ND, but it's like smaller diameter and has a magnet at the end of it, that GPS.
So no difference in mortality. With small bowel feeding, there was significant reduction in pneumonia compared to gastric with p value of 0.03. Without the study, that only 34% of patients were able to get access. There was only a trend in reduction of pneumonia. For length of stay, no effect, and no effect on ventilator days. So post-pyloric versus gastric, again, is the question. 5 studies showed there were feeding intolerance more prevalent with the gastric route. 11 studies showed a trend for less pneumonia with the small bowel route, and 12 studies showed no difference in mortality, diarrhea, or ICU length of stay.
So assuming we're saying trend that is not.
Trend is not statistically significant, exactly. It might be like close, like a p-value of like 0.08, but it's not actually significant.
Because
So,
Aspen recently, they released it for the pronation to use in
well, yeah, again, I didn't go into that.
Okay.
So no difference in length of stay, mortality, nutrient delivery, or incidence of pneumonia with either one. So kind of their overall recommendations. Since there's no mortality or length of stay benefit for small bowel versus gastric, if you can't obtain small bowel access, in a timely manner, then just start enteral nutrition via the gastric route. It's more beneficial than delaying feeding altogether while you're trying to get access. So instead of waiting for 2 days for IR to come up and put it, then just start gastric, and you can change it later if you need to. All right, so enteral versus parenteral Dpn. So is there difference in outcomes? So a meta-analysis of 18 studies, no difference in mortality in those, and this is just those that are receiving enteral nutrition versus parenteral, like they didn't really look at timing per se, but just whether they were getting one or the other. Those with enteral nutrition, of course, had a significant reduction in infectious complications. That's no surprise. Trend towards reduction in hospital length of stay with enteral nutrition, and significant reduction in ICU length of stay with enteral nutrition, but no effect on length of mechanical ventilation. There were 6 studies for the ESPN guidelines, 6 studies with ICU patients, and 7 that also included non-ICU patients, did show a reduction in infections, shorter ICU length stay, and shorter hospital stay with enteral compared to TPN. Dramatic reduction in ICU infections, of course, with EN. So basically, if oral intake's not possible, or they recommend early enteral nutrition rather than starting TPN. So basically, if the patient is NPO, and do you start enteral or parenteral? And the overall trend is decreased infections with enteral. This one was early enteral nutrition rather than early parenteral. No significant reduction in mortality, but again, reduction in infectious complications. So they recommend using early enteral versus early parenteral. There have been, again, few studies that have shown any effect on mortality, but the most consistent outcome is, of course, reduction in infectious morbidity and ICU length of stay using tube feeds versus TPN. There was, again, another meta-analysis comparing EN with PN. So in this case, there was a significant reduction in infectious morbidity and reduction in hospital length of stay. And then 5 of those showed no difference in mortality. Same thing with the other 12 studies there. So again, enteral nutrition over parenteral in those who need / all patients for nutritional support therapy. When should it start? So compared to standard therapy, and standard therapy meaning IV fluids or an oral diet, does parenteral nutrition result in improved outcomes? So should we put everyone on TPN that comes in the ICU, even if they have an intact GI tract? That's the question here. I think we all know the answer, but they did it just for evidence's sake. No effect on mortality. Only 2 of these studies reported on number of patients with infectious complications, and somehow it was not associated with an increase in infectious complications, which is surprising. No effect on
study and research, so they are like paying attention.
Exactly. It was parenteral nutrition associated with higher incidence of pneumonia, respiratory failure, acute renal failure, and catheter-related sepsis. So no effect on mortality, no effect on infectious complications, which I find hard to believe, but still. And it's also more costly. So, since there's no benefit, that means that you should not necessarily push for everyone to get TPN. This is in surgery patients. They either got continuous total TPN or just glucose, which I thought was kind of strange for 14 days. Of course, there was 10 times less mortality with parenteral nutrition rather than just pumping someone full of glucose. I think that one's kind of a no-brainer as well, but there it is. For mortality benefit in favor of parenteral nutrition compared with delayed, which is kind of strange to me, in a meta-analysis of 9 trials, there's no mortality benefit of parenteral nutrition, period, with early. But there was, sorry, yeah, I read that wrong.
The first line.
Right. Compared with, read that wrong, sorry. So in patients that you're giving delayed enteral nutrition, so instead of giving, not getting anything at all for days versus starting parenteral nutrition initially. Yes. So you're giving them something versus nothing, sorry. Overall recommendations, underfeeding or starvation leads to worsening outcomes. And they recommend that if you can't start enteral nutrition within 24 hours, you could, in theory, start parenteral nutrition. So low risk, again, that comes back to your Nutrix scores. If you had in a randomized controlled trial that had ICU patients with a perceived contraindication, using parenteral within 24 hours admission, there's minimal benefit seen over standard therapy. No difference between infection total complications, mortality, organ failure. So, no pre-existing malnutrition, so low risk. When enteral nutrition is not available, using standard therapies, IV fluids, reduced overall infectious morbidity versus parenteral nutrition. And then another aggregation of 4 studies, it was mostly surgical patients, significant increase in mortality with the use of parenteral nutrition, and more complications versus just standard therapy when EN is not available. So there's not a whole lot of good data about the timing. There was a study that showed after the first 14 days, continuing to provide nothing was significantly associated with mortality versus using parenteral nutrition. So, you know, if you've been there for 2 weeks and you're not giving them anything, giving them something is better than nothing. There were 2 trials that addressed the timing of initiation of just only TPN. So TPN was started on ICU day 3 in patients that had absolute contraindications for enteral nutrition, such as high pressors, and they had worse infectious morbidity and were less likely to be discharged alive than those who were started later, such as on day 8. So later TPN better than early TPN.
I think that's why you see sometimes surgeons just they use TPN
Yep.
early because they know, like for example, I am not using this gut for like this amount of days.
Yep.
So they're like, okay, that's not TPN. But it would be interesting to see, so we don't really deal with that as much.
Right.
But it'd be interesting to see, like, because sometimes COVID patients, they come in, you know, on non-invasive
You
support.
can't get
And
anything
now we know that they're probably not going to come off of it anytime soon.
Right.
So, you know.
And you definitely can't always get access because they come off and then desat. So
start them on feeds and stuff like that. So
And
what
the
do you
answer
do?
for that, stop the non-invasive intubation.
exactly. Intubate them. I don't need to feed them. Intubate them. It's
We had
fine.
this struggle in the ICU for people on non-invasive. I just wanted to point this out.
Yeah.
So we were even thinking about TPN.
Yeah.
We had a talk with the pharmacy.
Yeah.
So I would
That
say
comes up
PN,
pretty commonly,
okay,
unfortunately.
because there are 2 types of PN. There is TPN and
Right.
there is PPN.
Right.
PPN on its best situation is going to provide you with barely 20 to 30% of the nutritional needs. And to run that peripherally, you know how much fluid do they need?
A crap ton.
4 liters.
Exactly.
Which
So
is
in
like
COVID
not a big
patients,
deal
that's
in
not.
COVID patients.
Yeah.
It's fine.
Then you're going to switch to TPN. If you're going to talk
It's
TPN,
like
the
1.5.
struggle here is
Yeah.
it's 1.5 to 2 liters. You
Yeah.
achieve 70%. But still, the problem is going to be you have to lay your patient flat
Exactly.
to get a central line in them.
Exactly.
Because you cannot run it in the groin because they're going to get infected 100%.
Exactly. Period.
So this is one thing that we are struggling with
Yeah.
actually with.
And there's really no good answer.
No. We even tried like dropping NGs and NDs and feeding them, but you know, with the positive pressure, vomiting.
I think
think-
from pharmacy, but today pharmacy mentioned at least the patient should be 7 days. in
Right.
order to approve the TPN. I'm gonna clarify it today.
Yeah, it's not.
Based on these guidelines, yes.
Yeah, and the
That's
thing
where
is, like,
7 days
I
came
think the
from.
only like
But I mean,
critical
you
care
said
for
the
the United
earliest
States
can be
Society of
3
Critical Care, that's the only one that have the guideline. When you go to chest and everything, there's no like a guideline. But I think the three main question as a physician you need to answer for yourself, like as a critical care physician or as an intensivist, like which Mindy answered, or most of them. When do you start? What's the rate that you should start with? Can I start when patient on pressors? Can I start when patient on paralytics? Can I start when patient prompt? Those are the 5 main questions that has to be answered today before you leave this room. You should, not have to.
Keep going.
So when should you start parenteral in high-risk patients? And of course, high risk is the score greater than or equal to 5, or if they come in severely malnourished. Fewer overall complications with parental nutrition other than standard therapy. So if they're severely malnourished or at high risk, they would maybe benefit from parental nutrition early. So again, and then another one showed standard therapy associated with higher risk of mortality versus parenteral nutrition. So standard therapy, again, just IV fluids in someone who is severely malnourished and critically ill. So combination of enteral nutrition and parenteral. So does the combination result in better outcomes? No effect on mortality, no effect on overall incidence of infection with combined. Significant reduction in hospital stay though. Trend towards reduction of ICU length of stay and no effect on ventilation. So overall recommendations, there's no effect on mortality, there's no effect on infectious complications, but it is associated with a significant reduction in length of stay in the hospital and trend towards it in ICU patients. And then early versus delayed supplemental. So they're already receiving enteral nutrition and then you add in supplemental. So early versus late, no difference in ICU mortality, hospital mortality, or 90-day mortality. Significant increase in all infectious complications when you use parenteral nutrition early in addition to enteral. Significantly longer lengths of stay with early supplemental peripheral nutrition, and significantly longer time spent on mechanical ventilation compared to late supplemental. And again, late is, like 7 days. Another thing that they mentioned, the early parenteral nutrition had significantly higher incidence of sepsis compared to late parenteral nutrition. So again, they're already receiving enteral, and then you throw the parenteral on top because you don't think that they're getting enough calories or whatever. Okay. So hypocaloric, so low calories or low rate versus with late supplemental nutrition initiated on day 8 versus early, and in this case, early is on day 3. So higher likelihood of being discharged alive from the ICU with the late group, shorter length of stay in the ICU with late supplemental, and fewer infections with late supplemental. The optimal timing really isn't clear in someone that's getting, hypocaloric enteral nutrition or not up to par there. If it's, if the enteral nutrition is insufficient to meet the requirements at some point after the first week, then you should consider adding parenteral. But again, it's case-by-case basis. Overall, that was a lot of information. So early versus delayed nutrition in general. Early is associated with significant reduction in infectious complications, risk of infection, and reduction in mortality and infectious morbidity. Monitoring or not monitoring gastric residual volume. So higher amount delivered with a higher cutoff value, or checking it less. So more calories given, obviously. And no real change in outcomes for checking the GVR or GRVs more frequently. Continuous versus bolus. Continuous, you get higher amounts of calories delivered, and there's sometimes a reduction in diarrhea. Gastric versus small bowel. There is a reduction in the incidence of pneumonia with the small bowel feeding, but without one study, it only showed a trend. So it's basically the one study that showed it. Enteral versus parenteral. Significant reduction in infectious complications, length of stay, with early enteral versus parenteral. So parenteral associated with more infections. Less mortality for parenteral when compared to just glucose, but an increase in mortality with parenteral compared to standard therapy. So not just pumping them full of glucose. Combination of both enteral and parenteral, significant reduction, that should say reduction in hospital length of stay compared to just enteral alone, and then early versus delayed supplemental, late supplemental, associated with higher likelihood of being discharged alive, shorter ICU length of stay, and fewer infectious complications.
Thank you, Mandy.
Thank you.
So Mina,
So,
your question. Quick. So you said you were asking a question and then we stopped you. Sorry.
no, it was about how to calculate the caloric.
No, before that, you asked another question. I remember. What did you ask?
I asked.
He asked about